Here's some notes on airway management and airway injuries. First, initial assessment and approach. If possible, maintain spontaneous ventilation until the airway injury is isolated. You want to avoid positive pressure ventilation initially, as it can worsen the injury or cause pneumomediastinum. Patient should remain awake during initial management if possible. You want to visualize and diagnose the airway injury if possible. Direct visualization of the injury is crucial before any intervention. The preferred method is flexible fiberoptic bronchoscopy or rigid bronchoscopy, although this may be poorly tolerated in awake patients. The location and size of the injury should be identified to guide management. Your intubation strategy: awake fiberoptic intubation while maintaining spontaneous breathing is preferred. You want to avoid the blind passage of any tubes or catheters, especially if you don't know where the injury is. Direct laryngoscopy is not recommended unless the injury is known to be small and if you can see it on direct laryngoscopy. Endotracheal tube placement depends on the injury location. If you have a proximal tracheal tear, such as here on the background image, you might be able to place a single lumen tube beyond the tear and ventilate the patient appropriately beyond the airway injury. If you have a carinal or distal injury, you might consider a double lumen tube or bronchial blocker. So if you have an injury right here, for instance, maybe a double lumen tube can get past it, or a bronchial blocker can get past it. This is an airway injury here that's more distal to where a double lumen tube would be able to get, so it might be difficult to get past this injury. Sedation options include midazolam or dexmedetomidine, which can be used, but they might worsen airway obstruction. Other alternatives are ketamine or inhalational agents. You want to avoid jet ventilation. You have similar risks to positive pressure ventilation, which you wanted to avoid because it can cause pneumomediastinum or can worsen the injury. You also want to avoid LMAs. These do not secure or isolate the airway, and you usually place them blindly without direct visualization, so you might not be passing the injury, the airway injury. Muscle relaxants should also be avoided because they require positive pressure ventilation. A patient that is paralyzed cannot breathe spontaneously. The emergency management is a surgical airway, a tracheostomy, and this should be considered if the patient cannot maintain spontaneous ventilation, if fiberoptic intubation fails, or if the patient becomes unstable.